everyone, and welcome back to another exciting episode of MedSynapse podcast series. I'm Hetvisha, your host, and today we are tackling a health challenge that often goes unnoticed until it is too late: chronic kidney diseases. This episode promises to be an eye opener as we explore the latest developments in CKD management. And to explore this, we have a very special guest with us, Dr. Voon Ken Fong, a leading nephrologist at Gleneagles Hospital in Kuala Lumpur. With over 15 years of extensive clinical and research experience, Dr. Fong is at the forefront of advancing kidney care and treatment. His insights are invaluable for healthcare professionals looking to stay updated on the latest trends in CKD management. And we are excited to explore the latest insights and strategies for managing CKD. So, welcome, Dr. Fong, and thank you for joining us today.
Hi, hello. Hi, thanks for having me here. My name is Dr. Ken Fong. I'm a nephrologist practicing in Gleneagles Hospital, Kuala Lumpur, Malaysia. And I completed my nephrology training in 2022. And recently, I just came back from Barcelona, Spain for my training of a kidney transplantation. Yep. Thank you.
That is very interesting, Doctor. Thank you for sharing that with us. So now let's dive right into our main topic. Given the increasing prevalence of CKD, can you share some of the latest epidemiological trends, and are there any emerging risk factors that healthcare professionals should be aware of?
If you talk about chronic kidney disease, it roughly affects around 10% of the population globally, and that is around 850 million of the population are at risk of chronic kidney disease at the moment. That was according to the data being published in 2017. The prevalence of CKD, it varies according to the geographical region. So for example, back in my country, Malaysia, we have around 15% of adult populations having a chronic kidney disease at the moment. And this prevalence, it actually varies according to the different region, as I mentioned, but it affects mainly those low and middle income country. This is alarming, as we all know that CKD now is widely being recognized as one of the main factors that contribute to the death rate globally. And for example, amongst those high income countries like Singapore, Greece, Israel, chronic kidney disease is actually one of the top 10 leading cause of death. And let's talk about risk factor. As all we know, there are a lot of fast food chains in your country, probably everywhere now, like McDonald's, like Burger King. All of these can actually lead to many metabolic problems like hypertension, diabetes, and obesity. So, and all of these, right, can actually worsen kidney function in the long run. And in my country, again, around 50% of the population of kidney disease is because of diabetes. And around 35% of the patients with chronic kidney disease is due to hypertension. So this number truly reflects the danger of metabolic problem. And the other risk factors, for example, like genetic diseases, autoimmune problem, consumption of the toxic medications, or previous hospitalization of the insult to the kidney, and all of this can lead to the development of a chronic kidney disease. And lastly, there is an emerging risk factor. We call it as a chronic kidney disease of undetermined origin, or we call it CKDU. So it usually affects those people come from a rural area or agricultural setting. And the reason is unknown. Probably it's actually due to the exposure to the extreme climate condition, and maybe because of due to dehydration.
Yes, those are some interesting statistics, and I think various factors contribute to the effective of CKD. Now, I believe early detection is crucial in CKD management. So, what are the most effective screening tools and protocols that are currently available, and how can these be integrated into routine clinical practice to improve early diagnosis rates?
And if you talk about screening of a chronic kidney disease is very important, especially because if let's say we can detect them at the early stage, then we can implement a prevention strategy to retard the CKD progression. So that will actually save a lot of patients. But however, if let's say you are going to implement a screening program at a national level, they will cost a lot of money in our healthcare budget. So it's more practical to aim at certain population. That's what you call targeted population screening. For example, we will try to screen those patients with a risk factor like diabetes, hypertension, or heart diseases. Then they will have more effect. It will be more cost effective. And if we talk about the screening tools that we have, the most effective one would be blood testing for creatinine and also to check for any protein in the urine. And this test, right, is important because, right, they are going to let us to calculate the estimated kidney function. We call it eGFR. And based on the eGFR, we can stage the severity of a chronic kidney diseases. And at the same time, nowadays people are talking about AFRE, kidney failure risk equation. This is something not very new, but it's relatively new in certain countries. Like my country is very new. So how we use it is we're going to key in the patient's character, like their age, their gender, their ethnicity. Then we put in the eGFR, and also we put in the number of protein in the urine. Then that can tell us that it can estimate the risk of getting a kidney failure in 2 years and 5 years time. And this is important, then we can actually tell the patient what to do and what to expect in the future. So these are things that we can do for the patients. What about patients themselves? What they can do to actually to detect the kidney disease earlier? The most easiest way is to check the blood pressure at home, because high blood pressure, it could be an early sign of a chronic kidney disease. And other than that, self-checking the urine. If let's say the urine looks a bit foamy, a lot of bubbles, then that could be an early sign of a chronic kidney disease as well.
Yes, absolutely. I think early detection can indeed make a huge difference. So these strategies should be employed, and these tools are very effective. Now, moving on to the treatment part, what are the current approaches that are used for managing chronic kidney diseases? And could you also discuss how you approach individualized treatment plans, especially dealing with comorbid conditions and patient preferences?
Okay, so according to the latest guideline being published by KDIGO 2024, the management of chronic kidney disease, it involves multiple aspects. And it should start with always with the lifestyle modification and also diet. So for example, we will always ask our patient to take less salt diet, as low as 2 grams of sodium per day. That would be equivalent to 1 teaspoon. And also low protein diet, we are aiming 0.6 gram to 0.8 gram per kilo of the body weight of protein. Okay. And we also encourage our patient to take more fruits and vegetables to reduce the cardiovascular risk. But beware that most of our patients have a high potassium hyperkalemia. So you have to take into a consideration of their potassium level when you are taking a lot of fruits and vegetables. And we also ask our patient to stop smoking if let's say they are a chronic smoker. And it's advisable to reduce our body weight to maintain a normal body weight and a normal BMI. It's also advisable for them to have a weekly physical activities. It's advised to do 150 minutes of the moderate intensity of exercise per week. And lastly, we also ask them to control your blood sugar and also blood pressure. Try to maintain them within a normal range. So as you can see, we are trying to ask our patient to get involved in a lot of this lifestyle and diet modification. So we try to engage them with a dietitian and also a physical instructor as early as possible. as a complete care of chronic kidney disease. Okay, once this lifestyle and the diet changes are being optimized, then only we come into a pharmacological treatment. As you know, most of our chronic kidney disease patients, they have a higher risk of getting a cardiovascular problem. So we will start statin for the patients for primary prevention of heart diseases. And lastly, we talk about the renal protection agent. So the common agent that we use to protect our kidney to retard the CKD progression, it would be the RAS blockade, for example, ACE inhibitor or your ARBs and a SGLT2 inhibitor.
That's
So
interesting. And
yeah, I think you also asked me about the personalized treatment of a CKD, right? So to be honest, if you want to manage someone with a chronic kidney disease, it's not about a one-size-fits-all kind of approach when you're trying to see a chronic kidney disease patient. I'll just give an example. So let's say you see a patient, 80 years old, very frail, with a lot of comorbidities, can't take care of themselves. And in such a case, right, I would not go very aggressive for the patient. So instead, I'll discuss with the patient and also their family members what to expect. Okay, you have to take into a consideration of their age and their lifestyle and what patient wants and also what can the family support for the patient. So this sort of patient, if let's say they do not want to go aggressive and they want to go for palliative care, I totally have no objection at all. Okay, and conversely, if you have another patient, 80 years old, healthy, can even drive the car by himself, okay, can take care of himself independently, and let's say he has a kidney disease stage 5, then probably I'll explore more on what he wants. If let's say he truly understands the benefits and the risk of the renal replacement therapy, then I will support from my end. Yeah.
but it actually depends on how personalized and what can a patient do. And also,
Yeah.
initially, I would say that lifestyle modification is something that everybody should take care of.
Exactly.
Now, the field of nephrology is constantly evolving. So, can you talk about some of the most promising new treatment modalities, especially the role of SGL2 inhibitors in the current management of for CKD?
Okay, thanks for the question. If you look back in the guidelines of how we treat chronic kidney disease, right? Actually, we have no new breakthrough until the presence of SGLT2 inhibitor. And in the past, right, how we manage chronic kidney disease is always about RAS blockade, your ACE inhibitor, and your ARBs. So if you look at the timeline, so that is almost like 20 to 30 years later, only then we have the SGLT2 inhibitor. It's really the wonder drug of a century. So true enough, if you Google SGLT2 inhibitor, then they will mention SGLT2 inhibitor is a statin of 21st century because they save life. And SGLT2 inhibitor is actually originally designed to treat diabetes mellitus. Then eventually we have a lot of these landmark trials showing that they have benefits in the cardiovascular outcome. Particularly, they can reduce the cardiovascular mortality. They can reduce the rate of the admission to the hospital for heart failure, and etc. etc. But eventually, with all of the data that we have, then we look into the kidney outcome trial, for example, your DAPA CKD trial and your MPA kidney trial. These two trials shows that when we use the SGLT2 inhibitor in the patients with diabetic kidney disease and also non-diabetic kidney disease, they can actually retard the CKD progression and also reduce the number of protein in the urine. So SGLT2 inhibitor is really a breakthrough. Okay, I would say a game changer, and will change the treatment paradigm of the chronic kidney disease. So how these drugs work? SGLT2 inhibitor, right? They actually act on our vessels. What they do is they actually control our vasomotor tone to control blood flow to the kidney. And in that sense, the blood flow to the kidney will be constant and they try to maintain the blood pressure in the glomeruli of the kidney. So when your blood pressure is maintained, there's no high pressure in the glomerulus that can actually preserve our membrane well, and it will reduce the number of protein in the urine. And in the long run, it will protect our kidney and retard the CKD progression. The additional benefits of SGLT2 inhibitor include weight loss. So we can see patients on SGLT2 inhibitor, they have some minimal effect on the weight. And we all know that obesity can actually cause kidney to worsen. So weight reduction is actually a beneficial effect of SGLT2 inhibitor. And on top of that, SGLT2 inhibitor can also cause sodium loss in the urine. And you know, when sodium loss in the urine, they can help us to control our blood pressure. And water likes to follow sodium. When you're losing sodium in the urine, you are also causing a diuresis effect, losing water in the urine. And that would actually help us to control our fluids and reduce fluid overload in our CKD patients. And lastly, there are a lot of theory being postulated. If you use an SGLT2 inhibitor, they can reduce the inflammation and the oxidative injury in the kidney. That might reduce the fibrosis and the scar in our kidney, and it will protect our kidney from progression. I think that's basically very much about the benefits of SGLT2 inhibitor.
That is very exciting, the potential of SGLT2 inhibitors from diabetes to the kidney diseases. Now, we know that there are always challenges to manage these diseases. So, given the complexity of chronic kidney diseases, what do you find to be the most challenging aspect of managing these patients, and how do you handle situations where patients might struggle with adhering to treatment plans?
You talk about challenges in a chronic kidney disease. I wouldn't say it's a challenge, I would say it's something that actually why I'm interested in nephrology. If you ask me in the past, before I become a nephrologist, right, I would never think that I would become a nephrologist. And my initial direction is actually I want to be a surgeon. I want to be orthopedics. I want to be in a gynecologist. But eventually, something came to me where I saw a patient with a chronic kidney disease. That it changed my mind. When you see a patient with chronic kidney disease, that means, right, you're going to engage with them for lifelong. It's not like a surgeon cut and say bye-bye. No. Okay? If you see a patient with a chronic kidney disease, I'll give you an example. Let's say I see a patient 40 years old. Okay? Newlywed, newly married, very young wife, and the wife is pregnant. And at 40 years old, he got an end-stage kidney disease. Can you imagine how bad is it? And my job is actually to guide them, to lead them and tell them what to do. So among the treatment available for the end-stage renal disease, we have kidney transplant, we have a hemodialysis, we have a peritoneal dialysis. So all of these three methods, right, they have their own advantages and challenges. So he's young, of course, you try to convince him to get a new kidney. So if let's say he can get a new kidney, that will give him another good life for 15 to 20 years. And when the kidney graft fails, then we engage him probably for another transplant if possible. If not, then we try to transit him into a hemodialysis or peritoneal dialysis. That will give him another 15-20 years. So that means if you have an end-stage renal disease, it doesn't mean the end of the day. And you can engage with them lifelong, and you give them a prospect of how positive is the future. So once they know the concept and they know the idea of it, then they can actually face the future with more confidence and courage. So I wouldn't say it's a challenge. It's actually an interest of being a nephrologist.
Yes, I think with the right guidance, they can always choose the right path.
Yes.
So thank you for sharing those insights with us. But before we wrap up, here's one question from my end outside the main topic. So what do you think is the most significant breakthrough in nephrology that we might see in the next 5 years?
That is a very interesting treatment paradigm. It's coming soon. Just now we mentioned about the treatment of diabetic kidney disease. So the non-diabetic kidney disease, like we use a RAS blockade and we use the SGLT2 inhibitor. Okay, but if you look into the treatment of non-diabetic kidney diseases, right? Sorry, I'll try to change my phrases. Just now we talk about the treatment of the non-diabetic chronic kidney diseases. It's just only your RAS blockade and your SGLT2 inhibitor. But if you're looking into a diabetic kidney disease, there is actually four pillars of the treatment, how we manage the diabetic-related chronic kidney disease. So we use a RAS blockade, we use a SGLT2 inhibitor. There's two additional new medication. Okay, one of them is called new generation or novel MRA, and another one is a GLP-1 agonist. So these are the four main pillars how we treat a diabetic kidney disease. But on top of that, there's something more interesting direction we are looking into it is actually we try to stop the inflammation of the kidney. And that is something very new and we are looking for more data.
Thank you for sharing that insights with us, and it is so exciting to hear that. And as we wrap up today's episode, I would like to extend my heartfelt thanks to Dr. Fong for sharing your expertise and insights with us. It was a pleasure talking to you.
Thank you, Harry. My pleasure to talk to you as well. Thank you.
Thank you. And to our listeners, remember staying informed is key to providing best care for your patients. And if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay curious, stay informed, and take care.